really core to what it means to be Canadian, and a value of diversity as making us stronger, not weaker. That, I always grew up sort of hearing like Canada's more like a salad and the US is more like a stew, where we value the different flavors and how they complement each other, not the way that they just blend into one general flavor. And I think that has been my experience in Canada, that the different backgrounds and experiences from people who have lived here forever and those who came from elsewhere have made a culture that is actually really multicultural and beneficial. But what we all care about is making sure that we are healthy and well and thriving. And that's what I want to see in the health system. I want to see us value the diversity of healthcare provider types, of rural versus urban, of people with different backgrounds, different languages, and creating those systems where everybody gets access to the care that they need and can be supported to be as healthy as possible and thrive in their home community.
Hey everyone, I'm Costas.
Hi, I'm Lester, and welcome to What's with RWE, the Canadian Healthcare Podcast. And we have a very fantastic guest with us today, as usual. But the other special sort of announcement that we have with this podcast is now we have my co-host back. Costas hasn't been with us for the last couple episodes, so welcome back, Costas, from a little bit of a hiatus.
Yeah, no, excited to be back, especially for this episode. I think with the federal election right now, it's really timely to be looking at what we need to do in terms of shaping the future of healthcare. So I'm really, really happy to join you guys today.
Perfect. And thank you very much. Our special guest today is Dr. Joss Reimer. And welcome to the podcast, Joss. Thank you
Oh,
very
thank
much
you
for
so much
joining
for
us.
having me. This will be great. Looking forward to it.
Excellent. Of course, we're going to jump right into the conversation because there's so much to talk about. But I'll do a little bit of introduction for Dr. Joss Reimer first. She is the president of the Canadian Medical Association. So I got a list here to make sure I have everything down. It's quite a long list, everyone. She was the former chief medical officer for the Winnipeg Regional Health Authority. She also, of course, led and was the official spokesperson for Manitoba's COVID-19 Implementation Task Force and was the medical director of public health for Winnipeg. I believe you still maintain a clinical practice in maternity care at Women's Hospital. Okay,
Yep,
excellent.
that's correct.
Glad. And of course, maybe very interesting, you grew up in rural Manitoba. So we must talk a little bit about that. But welcome again to the podcast, Josh.
Yeah, well, this will be great. I love talking about healthcare, and the federal election is really front of mind for me right now. So glad to talk with you.
Yeah, on that note, maybe we just jump right into that specific topic. Obviously, there are many things happening in the world right now. Right now, today, just so everyone is aware, is April 8th of 2025. Upcoming federal election is actually end of this month. And of course, there's many things happening in the world, specifically, of course, everyone's, of course, talking about the trade and so forth with the United States. But obviously healthcare is a strong or core part of I would say probably Canadians' identity. So maybe Josh, maybe you could make the case, why should healthcare be a core issue? Why should Canadians care about healthcare this election?
Yeah, for me, actually, the economy and health are so deeply interlinked that I think it makes a ton of sense that we're focusing on the economy in the federal election. We've never seen tariffs like this. This is a complete shift to our relationship and our trading mechanisms. And so, at the CMA, we're not separate from that. We see the impacts, we're worried about the impacts, but we also know how deeply linked income and health are. So when we see these threats to our economy, and we know that income is the number one determinant of health, these threats also apply to our health. And we will see a worsening of the health of Canadians with our economy being attacked. And so we need a strong health system now more than ever to be able to help mitigate the impact that we're seeing on the economy. And on top of that, we get enough anxiety just looking at the economy. The last thing Canadians need is to add on anxiety about access to healthcare on top of that. So we want this to be a part of the conversation because it already is a part of the reality.
Terrific. Yeah. Yeah, no, I think I wanted to pull a thread on that because I think, the background in primary care, I think is really important here because I imagine that with income issues, primary care is where the need to access is the most acute already before income issues come into play. Can you speak a little bit about where we are today in terms of primary care access in Canada, and whether or not we're making headway? Because I think it's on top of mind for everyone.
Yeah, and to be honest, I would say that that's where we see the most struggle for Canadians. We hear regularly about people who don't have access to care. I was going to a meeting with a politician to talk about healthcare access, and the driver of my Uber was like, "Oh, I don't have a family doctor." Like, this is very real. We all have either ourselves or have a loved one who's experienced problems with accessing the healthcare system. And even Health Canada, they came out with a study this year that said we are 23,000 family physicians short in this country. Like, that's a pretty jaw-dropping number that we're not going to be able to solve with one solution alone. And that, fits with the previous studies we'd seen where there's 6.5 million Canadians who don't have access to a family doctor. And when you're looking at, prevention, when you're looking at people who already have conditions, but we're trying to prevent them from getting worse. I mean, this is where that core part of healthcare happens and keeps people out of the hospital, out of the emergency room.
Mm-hmm.
So it's a big problem and a costly problem when people can't get the care they need and they end up either trying to get their primary care needs met in an emergency room or not at all, or those primary care needs go unmet for so long that they become acute. And now they do need that higher level of hospital care to meet those needs. So this is something that is very real to all of us. We all ourselves or loved ones experience this. It's causing harm to Canadians and it's costly. It's when we pay at the hospital level, it's far more expensive than investing in the community.
Yeah. So, so what are some of the solutions that the CMA is advocating for? Because we hear a lot of dates and numbers. We're going to throw this much money at it. We're going to be, by 2026, we're going to be fine, or 2030, we're going to be, happy. Everyone is going to have a physician. But realistically, what are the things that need to change in order for some of these to be accomplished, for everyone to have a clinician, primary care
Yeah.
clinician, or access to a clinician?
Well, like I just said, when you're 23,000 physicians short, we're not going to have a one solution that fixes the whole problem. So we have to be working at every different angle all at the same time. So that means increasing class sizes, so medical school residency spots. Now that's going to take years because the average family physician has 10 years of post-secondary education, but still, so that needs to be happening. But we're not going to be able to train our way out of this. So we also need to be facilitating international medical graduates, those doctors who are already here, want to contribute, facilitating getting them safely into the system so that they can participate in providing care. That's really important, especially right now with what's going on in the US, facilitating US doctors who want to come to Canada. There's a lot of interest. We're hearing a lot from American physicians, so that's a big one. We also need to be doing things like team-based care because there's a lot of things that could be shared amongst a team and sometimes done even better by other team members. I think of my own practice where I saw mostly prenatal patients in a clinic, but we had a dietitian. And so when they had gestational diabetes or pregnancy related diabetes, they could spend time with the dietitian going through a low cost diabetes friendly diet. And then they would see our pharmacist, because we had a pharmacist as well, who would teach them how to use a glucometer to check their blood sugar. Like, that was a much better service than I could provide. And it took that weight off of my plate so I could see other patients and deal with their medications, their blood pressure, whatever other more complex issues they may have. So having that team environment helps us take on more patients, decreases the stress for physicians, which makes them less likely to decrease their hours and leave for other things. And we work better together when we share expertise. I also want to see us decreasing administrative burden because family doctors spend, depending on which research you look at, 10 to 19 hours a week doing paperwork. So, that's several days of paperwork in some cases a week. And if we can get rid of that, maybe through AI scribe, maybe through reducing some of the forms that we shouldn't have to fill out as physicians, or getting rid of sick notes. There's a lot of things we could do that could bring that number down and help us see more patients. But the key is we have to work on all of these things at the same time. No one of them is going to bridge that gap. And so we need to work at all levels of government, where we have control to make an impact.
Yeah, you spoke about a couple of these items, and of course we're going to dive deeper into each. Maybe not every single one, but a couple of them for sure, right? But just maybe this is probably not even a fair question to ask you. I don't know if anyone knows the answer to this, but I'm going to ask it anyways. Like, how did we even get to this point? Like everyone, I guess perspective is while I was growing up, born and raised in Vancouver, I always thought very, very like, oh, we had the greatest health care system. I just assumed so, right? So how did we get from like that point to this point? Was I just completely naive growing up, and then we got to this point? We're like, oh, actually, this is how it really is.
Yeah. I think I have a couple of thoughts on that. One is I still think we do have a very good health system. There's a lot of challenges. It is in crisis right now, but the system is a good system, and all countries have different challenges with their health systems. Many countries are facing crises right now, but there's a couple specific things that I think have really led us to the crisis point we're in right now. The first is just simple demographics. We have an aging population in Canada, and so there's people with more complex health needs who need more complex care. And that just is a reality. And it's a reality that applies to physicians as well. We also are aging. We have a big group of baby boomer physicians who are looking to decrease their hours, looking to go into retirement, and they had big panels of patients. And so we're seeing them dropping out of the workforce and then becoming complex patients themselves. So big problem just in the demographics of how many people are able to provide care, how many people need care, and how complex that care is becoming. The other issue, though, is that in the 1990s, there was a belief in Canada that we had too many doctors. And so we actually decreased our class sizes across the country and cut funding for training of physicians. And so I think we're seeing now that that was quite a short-sighted approach when we knew this demographic change. We already knew the demographic change was happening then, but it was so far into the future, it was easy for politicians to push to the future. We think in 4-year cycles in politics. And so that decrease means that people who would be sort of mid career right now, taking on probably the most amount of work, the people who have, their kids are grown, but they're not ready for retirement yet. They're really, that's where we have a smaller cohort is in that age group. And so that's also really challenging the system. And then COVID came and so we had all of this underlying stuff happening. And then suddenly we had a global pandemic. We burnt out a bunch of our healthcare providers. People have long COVID now. There's more complex health needs because of that. COVID's still here and still adding to the burden. So all of these things have compiled in this sort of perfect storm to put us in the crisis point that's now going to take another hit because of the economic situation that we're in. And costs are going to go up within the health system. And that's going to create additional barriers for everyone. So, it's, even though we're working on solutions and I feel very optimistic about some of them, with this economic situation, that's going to add another challenge for the healthcare system.
Yeah. I remember the 90s when everyone was so worried about the costs, and the easy way was, hey, if there are fewer physicians, they can't
Yeah.
charge in the fee for service model. So it's just going to make it cheaper. Yeah. Unfortunately, very short sighted. But,
Yep.
there is one thing I did want to, you touched on very briefly there, and that's the sort of the burnout factor, I think, or more in general, the mental health of clinicians. The volumes that they are managing have gone up per individual. And COVID certainly did not help that situation. I know personally within my sort of family practice that we attend, we lost clinicians during that period who, once they came out of the emergency, said, I can't do this anymore, and decided to step away and take a different role. So how, from a CMA perspective, how do you guys look at addressing burnout and trying to ensure that the clinicians that are there are capable of day to day
Yeah.
carrying out the loads that we're putting on them, or that we foisted on?
There's a few different things at the same time. And I'm someone who has gone through burnout. So I care a lot about this issue. And I've been really open about my mental health experiences. Um, but we need to both help manage people who are already having symptoms of burnout, experiencing some of that stress, while also trying to create a system that prevents it in the future. And I really think the prevention is the more important part, but we can't ignore the people who are already struggling. So the tendency is for us to think, well, we need to put in these programs to help physicians cope, and we do. I've benefited from them myself. We absolutely need to have some of those stress management tools. We need to have counseling services. All of those kinds of things that help people build resiliency. But that doesn't solve the problem. That just sort of waits until we have more physicians who are struggling, and then we just try to manage them instead of acknowledging what created the problem in the first place. Because it's not the physician that created the burnout; it's the system.
Yeah.
So at the same time, all of those things that I talked about, how I want to improve family medicine, I mean, they really apply across all of medicine and contribute to burnout when we don't have them. Because burnout is not just about how many hours you work, although that can be part of it. It's really about, do you derive meaning from your work? Do you feel valued? Do you feel like the time that you're spending on different activities contribute to what you're trying to achieve in your job? And so the people who are spending 19 hours a week on paperwork are much more likely to experience burnout because of, especially when it's paperwork that's unnecessary, that's not meaningful. And you certainly don't feel valued, especially when you don't get paid for doing a lot of that paperwork.
Yeah.
So those are the people who really start to experience symptoms of burnout when they are feeling undervalued, when their work is a blend of some meaningful work, but a lot of meaningless work. Um, and then just all the trauma that was experienced during COVID, adding an additional mental health element. I wonder, I don't have any stats on this, how many doctors and other healthcare providers have symptoms of PTSD from going through that. It's having worked in, when you're all in that gear all the time and seeing people so ill, and we didn't have good treatments at the beginning, like that was a really traumatic time for a lot of people.
Mm-hmm.
So that, together with the typical professional burnout syndrome, is creating a lot of stress in our workforce. And we need to be both providing supports to the people going through the stress while trying to make the system better to allow doctors to do what they do best, and that's care for patients.
Actually, on that front, there's maybe two things that we could go down, but maybe the first one around administrative work, because I actually, quite honestly, I don't know what that looks like. So maybe you can walk us through potentially a case of with like what is that additional the added sort of administrative burden, because I actually just recently listened to a podcast on Freakonomics, and they actually call this sludge. Right? I guess
Mm,
like work that
yeah.
doesn't really necessarily need to be done, but it's like there for some reason, right? And the kind of the best example they talk about is this door. The door that has a handle where you're supposed to like push, but you pull
Oh,
for
the
some stupid
Norman door.
reason. Yes, the Norman door.
Yeah,
Exactly. So they call
yeah.
that like sludge, like things that shouldn't really exist that give you extra work. So maybe you can go through what is this administrative sludge that you have to go through as a doctor. If I come see you as a patient, what does that look like?
Yeah. Well, and so not all paperwork is, unnecessary administrative burden. We know some element of paperwork is required because we need to keep records. That just is. You have to be able to record what happened during a patient visit so that the next time you see them, you know what happened last time. We're not going to memorize people's health. And when we go between providers, they need to be able to share that information. So writing a consult letter, for example, that is something that has to be done. Now, maybe there's ways we could do it with AI, or not even AI, with scribes that are real people, or AI scribes. There may be other solutions, but that communication still is going to have to happen. Where we get particularly frustrated is the type of paperwork where it's like disability forms. And now somebody's qualified already provincially to get disability assistance at the provincial level, but the feds have a completely different form that requires totally different paperwork. It's, 30 pages that you're filling out, and you're assessing things that you're like, I don't know. Can you carry a laundry basket up the stairs? I've never seen you carry a laundry basket up the stairs. Like information that the physician also doesn't even feel like they can really do. So pages and pages of filling out forms that the person's already done for a different program on the same topic. This is where people get really frustrated. Or sick notes. When someone's had a cold or a migraine and their employers require them to come in, and they come in usually days later when they're feeling better. And so I'm sitting there just filling out a thing saying like, they told me they had a headache. I don't like I can't prove that they had a headache. And so now I'm doing this paperwork, and I've had it where the employer didn't like the way I wrote it. So then they come back and I have to rewrite it. And those are the types of really frustrating circumstances. And then there's just simple things like you have to put all the identifiers on every lab requisition. So you're filling out, and I've had lab samples sent back because they didn't have like 3 unique identifiers. And, sometimes people are using their Indian status card, and then some labs don't like the status card as an identifier. And so they send it back because they want to see their provincial health number and their date of birth. And you chose the wrong ones, or you took the wrong, different labs will give you different forms to fill out. And so you accidentally filled out for lab A, but the person who didn't know that went to lab B and they won't accept it.
Hmm.
So these are the types of very frustrating circumstances where you're repeatedly doing work that doesn't feel like it's contributing to the health of your patient in any way. And that's the kind of stuff that we really need to have all levels of government work together to improve. Because, if the province has already approved somebody saying they have a disability, if they don't have a leg, it's not growing back. And yet, with the federal forms, every 5 years, you have to re up. And so it
Right.
doesn't matter if it's a permanent disability, you have to prove it again 5 years later. No, I still don't have a leg. So working together between levels of government to get rid of some of these forms would be really helpful. Having the labs use standardized processes for what requisitions work, bringing in AI scribe, because that can help us write our notes, write our consult letters. We still have to review them, but I think we all know that editing a document's a lot easier than doing one from scratch. So there are great solutions out there, but right now it kind of feels sometimes like you're in a hamster wheel and people are just throwing random pieces of work at you while you're running in this wheel.
Wow. Honestly, it sounds like there actually is some low hanging fruit that can
Yeah.
do some good. It's just a willingness a component that is in question more than anything else. So
Well,
that's
we've seen some
incredible.
positive steps. Like Nova Scotia had an administrative burden red tape reduction task force, and they did do some simple things like in their hospitals now, instead of having to log into every system, your badge just taps you into the computer system. I
Hmm.
mean, if you think about how many times a day am I logging in when I'm at the hospital, and even if each one takes 1 minute, if I'm doing it 60 times a day, 100 times a day, how many minutes am I spending? So they put in stuff like that where you just tap into the computer system and now you're ready to go. Uh, Ontario and I think it was Nova Scotia also came up with legislation that limits when employers can ask for sick notes. They're not gone, but you have to be out for at least 3 days or 5 days. They're all slightly different. I mean, so there's some good steps. We just need to keep going.
Right.
Yeah, no, that's fascinating. I didn't know that. That's actually it's I can laugh at it, but I assume it like really eats at your soul
Yeah.
when you talk about some of this type of things. I actually wasn't aware of that at all. But the other piece that you talked about from hopefully alleviating burnout. Of course, there's managing it, but there's also alleviating it. Is this team based approach? Maybe you can speak a
Yeah.
little bit more about this integrative team based approach, which I think is quite interesting. And for instance, maybe if you can layer on top of that, is there a role for a nurse? What's the term for nurse practitioners to be a part of that overall
Yes.
care system as well?
Absolutely. We love nurse practitioners on our teams. There's such a great complement to the physician, and the way we can divide our work is wonderful. And then the way we can collaborate. And sometimes when you have a tricky situation, to have that other person who has a slightly different training, different perspective to share their expertise can be so wonderful. So, team based care is beneficial in a few ways. First, it's just beneficial because we can share the patient load. We can increase the number of people who can be seen by that one clinic, that one family doctor. But I think also what I'm saying is it reduces some of the mental load from the physician because they've got those different experts. I don't have nearly as much nutrition training as a dietitian. And so just knowing that I can send them to that dietitian is so helpful. Or, like I said, we also had a pharmacist. And sometimes I was trying to figure out, what medications are covered by the First Nations Inuit Health Branch, which ones aren't covered. But she just knew and had a system and could look it up. And so we could find, and doctors often don't even know how much medications cost. And so sometimes I was just like, oh, what's the cheapest of these options? Because clinically they're pretty similar. And so I had a pharmacist who could be like, oh, no, rabeprazole is your cheapest drug for heartburn. So yes, you can give esomeprazole. It's a new fancier one, but it's way more expensive. And just having that person that I could share information with was so incredibly helpful. We also had nurses, we had physiotherapists, an occupational therapist. So I sent a lot of patients when they had, pregnancy related joint pain to see our physiotherapist, because there's not really much they need from me as the doctor. We just need them to do some strengthening exercises and get them through this pregnancy so that their body can recuperate afterwards. So sometimes they would come in and not see me at all. They just would come in, see the physio, get some attention on their hip, go home, and then see me at the next visit. So this is helpful for the physician. It's great for the patient because they just get the care from the right person at the right time. And then the key part is that we have to share a space, we have to share a health record, because when we're working in silos, that it's not a team anymore. We're not able to share our expertise. Instead, we're going to be duplicating our efforts. The pharmacist who works at the pharmacy might prescribe something for a urinary tract infection, but I know they've actually had 3 other urinary tract infections or bladder infections this year, and that medication's not going to work. So we need to be working together where we share a health record, we share space, we can talk to each other. But that is excellent for burnout, it's excellent for patient care, and it's more efficient.
And actually, just while you're just speaking about this, I kind of came up a little bit of an analogy in my head because I assume some people may be thinking, oh, you know what, like doctors, like why do you need so many people? Shouldn't you know everything? I
Mm,
want care from you, right? But I just thought about this. It's like a restaurant. A restaurant is like a team of people that serves an individual. Can you imagine if the chef was the only person that had to take your order? They were also one that had to give you the bill. They had to come give you the water and then go back and cook. It'd take forever, right?
yeah,
Like it would be a terrible experience in some ways, right? Unless the flip side would be you would pay a lot, right? If you went to a restaurant that the chef did everything, right? They could only serve a very finite amount of people, and it would cost like $10,000 for that dinner, right? So
yeah,
it's
that's a great
kind of
analogy.
interesting that in some ways a team, it just makes sense. Like everything else you kind of service you get in life, you have a team that's really actually helps you and serves you. Like why shouldn't medical kind of medicine
Mhm.
be done that way as well?
And we have actually surveyed patients. And so we know that people do, they all want a family doctor. So telling them, like, oh, you'll just have somebody else, they don't love that idea. But what they also tell us is they're very happy to see other members of the team when it's a team based approach. So that's clear. People are very comfortable with the idea of a team. They want to know that the family doctor is there because sometimes they're going to need that care, and having that link and that person who is trained to do the more complex diagnostics. And I mean, family docs are amazing diagnosticians, is what we call, because they take somebody who comes in with the most vague health issues and have to just figure it out amongst everything it could possibly be. And very few specialists have to do that. And so having them on the team is really core. But the nurse practitioners are really strong at things like preventative care. They do such a good job and they're more cost effective when they're working in a team with physicians at providing some of that care and taking that off the plate of the physician. So I think they work really, really well together, where they can have the nurse practitioner can provide a ton of the care. The majority of care for many patients can be dealt with by the nurse practitioner, but having that physician there to help when something gets complex is also less stressful for the nurse practitioner.
Got it. And so obviously right now it's election time, right?
Mm,
End of this month, there's going to be a federal election. And so far, I might be completely wrong about this, but it seems like only one of the major parties recently released their platform. And I'm sure you've gone through it already. One of the things I think also aligns quite well with the CMA's platform as well was this idea of there are like I guess there's foreign doctors that are Canadian. There's Canadians who had foreign degrees of medical degrees, and they're in Canada. And there's a barrier for them to practice in Canada, and one of those barriers, it seems like, is this residency. And there's this idea, I think the NDP and Jagmeet Singh recently talked about this idea of increasing the number of residency spots. So I don't, of course, not being in like knowing the process itself, like is that true? Is that issue and why is it that we have so few residency, and what is the process of kind of like doing that? Like, what is it,
yeah.
purely a money thing that you have to just give money to increase the number of residencies, or is much more complicated than that?
Yeah, that's a great question. And maybe I should explain, just because I don't know with your listeners how many have any idea how medical training works. So, most medical schools in Canada, you have to have an undergraduate degree just to get in. And that's almost standard across the board. And then most medical schools are 4 years of medical training. So you spend usually the first 2 years doing more, the theoretical, more in the classroom type of learning, and then you spend the second 2 years doing stuff on the wards where you're actually learning more from directly from the doctors with patients, providing care to those patients. So at the end of those 4 years, you have to then decide what specialty you're interested in. And we have something called CARMS, which is the Canadian Resident Matching Service. And it is a computerized system where all of the fourth year or final year medical students in Canada, they put in their preference for where they want to go to residency across the country. And all of the programs across the country put in their preferences about which students they liked. And then the computer just spits it out and tells you where you're going. And so this is something that usually Canadian medical students, they get first dibs on that matching service. And then everybody who trained outside of Canada, even if you are a Canadian citizen, if you trained outside of Canada, you get sort of whatever spots didn't get filled, they'll do a second round. And usually the international grads get added in that second round. When it comes to how many residency spots there are, money is part of the issue for sure, because you have to pay all of them. We pay our residents. We don't pay medical students, but we pay residents. Residents are people who completed medical school, they're doctors, but they're now specializing in family medicine and obstetrics and surgery. And so they get paid not as well as when they're done, but they get paid and they work very, very hard. So part of it is pay because we pay all of them. But the bigger issue is really, are there enough people to train them? Are there enough physical spaces for them to work? What we've heard from some of the family doctor offices is, well, great, I'd love to take more residents, but I only have 2 offices and like 2 desks. So I can't really take more than one learner, because where would they work? I don't have another computer. And especially for the family doctors that are private businesses, because a lot of family doctors, they run their own clinic as a private business. They hire all the staff, they pay the rent. Like, are we going to ask them like, oh, if you could just renovate and build an extra spot to train another resident? Like that's not really a fair request. So that becomes a big challenge as well, as do you have people who are willing to teach and take time away from making money, because we don't usually pay them to teach. Do you have the physical space and computers and the beds for examining and all of the equipment that's required to train? And that becomes a challenge. And even in the hospitals, you want the residents to get a good experience seeing enough cases. And so you have to make sure you don't have 10 residents attached to one surgeon, because, well, one of them's going to get to do the surgery. Like, that's not good learning either. So all of that is happening. At the same time, the Canadians who have gone abroad for their medical training are probably some of the lowest hanging fruit to get physicians into the system quickly, because they are probably going to stay in Canada. They're from Canada. They're more likely to go back to their home community. So they probably speak the language. They probably have a good understanding of the culture. There's a lot fewer barriers for those folks. And if they can jump in straight at residency and not have to do the 4 years of medical school, the undergraduate degree, for family medicine, that's 2 years of training instead of the whole 10. So if we can increase those spots, so meaning we need to make sure we have the infrastructure, we have the instructors, that's a much faster way than just trying to get brand new Canadians through our 10-year system to become a family doctor. And my brother-in-law is one of those Canadian, but went to Ireland for medical school and then had to match through CARMS. And your likelihood of matching is very low as a external candidate. So he was really lucky. He did match, but most don't. So this is something that is both low hanging fruit, but also still not as simple as just saying, well, let's just increase the spots.
Rats.
Yeah.
I was hoping it was so
Really
much
long
easier.
answer, but
No, this is great. This is great. We love these deep dives, sort of deep exploration nuances. But just to clarify, just for my sake here, is from when someone gets matched in CARMS, that's for the
mhm.
residency. Oh, I see. Got
Yeah.
it. Got it. And
Yeah.
then
So
from
that's
there,
for usually a 2 to 5 year, although some programs are longer than 5 years, but most are either 2 or 5 year program in the specialty, hopefully of your choice.
got it.
So you mentioned earlier that there's a lot of interest today from Americans who are looking
Yeah.
to. So what is the profile of someone like that? I mean, are they Canadians who, went down in the 90s or 2000s, let's say, and they're looking around them and saying like, I don't recognize this place anymore. I kind of feel homesick and I want to come back, or is it just Americans who are just looking at it saying, I don't like practicing. This is not what I didn't want to get into the world of insurance, and I want to go somewhere where I can actually practice medicine.
Yeah.
What did these people look like?
I don't know if we have the stats yet on exactly who it is, but what I'll say, I can definitely talk anecdotally because I've connected with some of these people on social media. We've seen news stories about some of them, and what you just described is what we're seeing. It's a
Mm,
lot of Canadians who chose to go down because you often can make more money working in the US, but you work in a system where the insurance companies get to decide how you practice medicine.
mhm.
They do more paperwork. I said 10 to 19 hours a week for our docs, so they do more.
Yeah,
So they also get sued a lot more just because of the way their system works. So you have to be open to the idea that you are likely going to get sued at some point in your career in the US, where in Canada, most of us don't. Still not impossible. Um, and then political interference is a new big concern. And so I think we're seeing a
mm,
new increase in interest, both from Canadians who are down there as well as Americans, saying, I don't want to be told by a politician what is or isn't medicine, what is or isn't the best decision for my patient. Like, it was bad enough when the insurance company was telling me what to do. Now politicians are telling me what to do with no medical background, no understanding. And so
yeah,
I think that's what we're seeing, an additional spike is, particularly with the push against diversity, equity, and inclusion in the US. There's a lot of physicians who are Black, Indigenous, people of color, women, part of the 2S LGBTQ community, who are also feeling that, is there a safe future for me here? And so seeing a country where, at least in part of the country, speaks the same language, where it has many overlaps in the culture, overlaps in the food, overlaps in how some of the things in our society are structured. It's not physically very far away. I think there's a lot of attractive things about Canada, in addition to not having to deal with insurance companies, at least rarely having to deal with insurance companies, not having our politicians tell us what is or isn't medicine. Lots of challenges. We've talked about lots of challenges in the Canadian system, but the biggest thing is we just actually need more doctors. So them coming
yeah,
helps solve some of our biggest challenges. Uh, so yeah, some of the examples is we've seen a lot of interest from obstetricians. They're particularly in the southern states. They're feeling like they can't practice the way they were trained, and are looking to be able to contribute to a community using the skills that they were trained to do. And so I think Canada makes a lot of sense for many of them.
yeah.
And actually, on that, still pulling on that thread. If say, actually my wife is American. If she's not a doctor, but she was a doctor and she was practicing in the U.S. for I don't know like a decade, and she wanted to come up to Canada. Like, what is the process? Is it well? Obviously, there's an immigration component too. But aside from the immigration piece, how do they become a doctor in Canada? Do they have to go through the CARMS as well, or go ahead?
Probably not. Most of the time, we would recognize US licenses because their training is similar enough to ours. And for the most part, that we know, we're very familiar with the caliber of their universities. They actually have a lot more variation in the caliber of their medical schools. Canada has much more consistency across the board of how well we train physicians. They have some really strong, excellent schools and some less strong schools and training programs. But I would say across the board, they tend to meet a level that we're comfortable with. So they don't usually have to retrain when they come to Canada if they trained in the US. It's more a recognition of their training. So they need to apply for a license, which is done at the provincial level. So they have to apply at whatever province they want to go and work in, and have their training reviewed by that college in that province. And that's going to cost them, thousands of dollars. It takes time. There are a few provinces now that are fast tracking that for US physicians. I think there's four, and don't ask me which four because I don't remember, but Ontario is one of them. And so, our biggest province is one of the ones that is fast tracking US. It's not where I live, so I don't, I hesitate to advertise that Ontario is accepting them when I don't believe my province is one of the top ones for fast tracking yet. But there are several provinces that will fast track U.S. trained physicians to get a license here, but they still do have to do the immigration thing. So that means getting a visa, and sometimes it means we have to do labor market assessments to prove that we have a need for this type of worker. And that means you have to post a position and prove that no Canadians filled it, even though Health Canada is the one that produced the report saying we're 23,000 family physicians short.
Right.
So even that's out of our control as physicians. But even on the immigration side, there's some challenges that we're hoping the federal government will see as not conducive to the improvements we want to see in our healthcare system.
Again, the administrative burden poking its head.
Yeah. Yeah. I mean, that's not something that once you're here and practicing, you have to deal with, but it seems very unnecessary that we should have to prove that we couldn't fill a position with a Canadian doctor when it's the government's own report saying we don't have enough of us.
Yeah. Can I just sort of talk a little bit about the U.S. maybe, because it's we've often been fairly lockstep in terms, especially public policy around healthcare, and with our the change in leadership there with RFK Jr. taking the reins, we've already seen maybe some change at the top. Maybe not down below where the science and the medical practice is, but sort of a change at the top in terms of around vaccinations, preventative measures such as fluoridation of water. We've typically been lockstep. Here we might start see a divergence. What is the approach that Canada is taking to ensure? Because I think we've seen some of the same questions pop up in Canada from folks. Should we be doing vaccination? Should we be doing it? So how do we address it here in Canada, knowing that there is this loud voice across the border and a lot of policy change that is potentially going to happen, at least for the next 4 years? So how are we sort of protecting ourselves maybe from that pressure?
Yeah, well, the first I would say with the lockstep, I think that's true for maybe our public health approaches, but not for the healthcare system. We're actually quite different. And the Canadian system is much more similar to our European counterparts. And even there's a lot of variety, but we're much more similar to most European countries' healthcare systems than we are to the US. They are standalone. There is nobody else in that category.
Yeah.
They spend far more money per person on their health system, and even tax dollars. They spend more tax dollars per person on their healthcare system than we do in Canada, which is baffling to me because that doesn't include the insurance costs, that doesn't include out of pocket. But when it comes to public health approaches, with the CDC, for example, and the Public Health Agency of Canada, we absolutely were quite well integrated partners. And we depended on them as a source of information, as a trusted partner, and it was a given that they would be there to share scientific information, scientific consensus, that they would be putting out messages that promoted public health. And I don't think we can trust that's a given anymore. And that is a very new environment that Canada is going to have to learn to navigate. Websites like the CDC have been scrubbed of different terms that the administration doesn't like.
Yeah.
Their data sets have been altered to remove categories of people. So information, like they had contraceptive guidelines that I know obstetricians and gynecologists in Canada used regularly with their patients. That's gone. It's not there anymore.
Mm-hmm.
So the resources that we used to see as a given in the US are either gone completely or are no longer reliable because they've been tampered with or may have been tampered with. And there's no way for me to know which data sets have been altered or not altered, but I know some have. And so we are going to have to create a lot more resources within our own borders that Canadians will be able to go to. Because I used to send people to American websites all the time to get information, and I'm not sure if I can do that anymore. So I really want to see Health Canada, the Public Health Agency of Canada, strengthen their websites, make them easier to navigate, make them trustworthy sources of information for all Canadians to go to, and also support the organizations that are doing similar work. You know, Diabetes Canada has great information. The Cancer Society, the Society of Obstetricians and Gynecologists, they have a page on sexual health, on pregnancy, on menopause. Like, these are great resources, but we're going to have to invest more into making sure Canadians know where they are, know how to access them, because we just can't depend on our partners. I just saw a headline, I think this morning, about how the Health and Human Resources are going to be looking into whether or not fluoridation is beneficial or not. This has been looked into so many times. We've seen Canadian cities that removed fluoride, saw their dental uh, disease skyrocket, and put it back because of that. Like,
Yeah.
we have case studies of populations of over 1 million people where we saw the harms of removing fluoride from the water. We don't need to study this, and especially when they've slashed research funding across the board for new pieces of information, to then go and spend time studying something that we already know is so disheartening. So, you know, if you remove fluoride, we know kids are going to get cavities, they're going to lose their teeth, and that's also linked to all kinds of other health problems as well. So this is hard to watch for the sake of our American colleagues and the American people and the harms they're going to experience. But even within Canada, we're going to have to really invest in making sure that we can provide those sources of information, because we are going to be bombarded by the messages that come across the border. We already are.
Yeah.
Yeah, speaking about, tying it back to something you talked about previously around, I think you were talking about doctors in Ontario. I think fast tracking doctors in Ontario, and then your province of, you live in the province, I assume, of Manitoba. Are
Yes,
you in Winnipeg? Okay,
I
perfect.
am. Yes.
Excellent, excellent. So actually, there's a lot of talk about interprovincial trade
Mm,
barriers, right? Which
yes.
I didn't even know existed. That sounds like somewhat like so ridiculous, right? So apparently there are interprovincial barriers for medicine too, and I wasn't aware of this until my wife had to go through a medical situation where she's like one of these people that researches a ton of stuff. So she's like, "Oh, this seems like the best treatment." Talks to a doctor, is like, "Actually, you can't get that in BC. You can get that technically in Alberta, but not in BC." And that actually flabbergasted me. We were like, "What? That doesn't seem like it makes any sense." So maybe you can speak a little bit about these interprovincial barriers to practicing medicine, and then some of the, hopefully, seems like there might be some low hanging fruit that I don't know if your team has identified that could be just removed or alleviated.
Yeah, we talk about the Canadian health system like it's one system. It's really more like 16 systems, because each province and territory has its own, and the federal government runs three health systems, as they run corrections, First Nations communities, and the military. So we have 16 independently run health systems in this country, and they're similar. They're all similar. They're not identical. And so, you know, what fertility treatment is covered in one province may not be covered in another. What medications are covered through pharmacare or not pharmacare differs. I had a friend who couldn't move out of Saskatchewan because the medication he requires is so expensive, and Saskatchewan covers it, but Manitoba didn't. And so he couldn't move here because he couldn't afford his medication if he left. And these are not rare stories. Fortunately, we're similar enough that most of the time, you know, if you need your knee replaced, every province is going to offer that. But there are these gaps or differences on some topics. And then the other thing is that for healthcare providers, I'll talk about physicians because that's who I represent, but it's not unique to physicians. We can only work in the province or territory where we're licensed. We can't work across the country. So even though labor mobility is a right in Canada, you have the right to live and work anywhere in the country. I'm not licensed outside of Manitoba. And so that can cause a problem if there's an ER that's going to shut down for the weekend in another province. I can't just go help out. Now, first off, I'm not an ER doctor, so I definitely shouldn't go and help out. But let's say I were. I can't go do that because I would have to apply to the college there, wait for them to approve me, pay thousands of dollars to get a license in that province. No one's going to do that to help out. Maybe if you're gonna move, sure. If you're gonna work half of your time there, maybe. But to be flexible and respond to things, nobody's going to do that. There's I live in Winnipeg, and 2.5 hour drive to Kenora ER, I think it was this past summer, was threatening to close down. I can think of so many doctors that would love to go to a lake country for the weekend, do some ER shifts, go out onto the dock with a drink at the end of the day, but we can't. We can't go help out and prevent their ER from closing. And that's so unfortunate because I'm sure we would have people willing to do that. Another example, when Yellowknife Hospital was evacuated because of wildfires, the doctors and patients were evacuated together, but the doctors weren't allowed to take care of their patients when they got to the other province because they didn't have licenses there. So they had to find local doctors to take over the care of those patients because they weren't licensed. Makes no sense. We need to have the flexibility to respond to urgent issues. And if maybe there's a northern community in Saskatchewan that just needs somebody for a week every few months, if I didn't have to pay thousands of dollars, yeah, like I'd come out for a week every few months, but it may not be worth it for people if they're going to have to go through all of that work. So we are really hoping that, if not now, when, with all this talk about interprovincial trade barriers, that we can get all of the health ministers, because that's who we really need on board here, to agree. And we need to do this. The Atlantic provinces are already a bit ahead of us on this because they have an Atlantic register. You get your license in one of the 4 provinces, so you already paid thousands of dollars for your license. Pay an extra 500, and then you can work in all 4. So better. It's still not the ideal, but it's much better. And so we want to learn from that experience and hopefully get this across the country so that we don't have to see people who move and can't get a doctor in their new province, and then their old doctor's not allowed to provide them virtual care anymore because they aren't in the same province. That's just a gap we don't want to see anymore.
Out of curiosity, then, if in this situation, say you are a doctor in Alberta or Manitoba, and you're sort of somewhat of a late night owl and you like to work a lot for some reason, right? So you could you take an appointment with someone in BC via virtual conference? No, you cannot. Okay,
No, not
interesting.
unless you're licensed in BC. You have to be licensed where that person works, where that person is physically located at that time. So
Okay.
even if my own patient goes to BC and they don't live there, I can't technically provide them care while they're in BC.
Oh wow. So just if their physical location either
Yeah, and
permits you or just
different colleges may interpret those situations differently, but technically, I'm supposed to only provide care within the province of Manitoba.
well,
Well, I know we're up against time. So Costas, sorry, you got your question? Go ahead.
no, I was just going to say the same thing. I know we have to let you go. You're busy right now, but maybe just we'll give you the sort of the floor for a last comment. People are looking at this election. What are from your perspective, the last thing people should be thinking about with regards to healthcare when they're looking at who they should be voting for? What are the key things that they need to be thinking about?
And maybe if I can layer on there
Yeah.
before you go into your speech here is it's a little bit of a pothead question, but kind of layers into what Costas is saying. I was talking about how for me actually our sovereignty being attacked, right, makes me actually made me think about, well, what makes me Canadian, and it was actually kind of hard to kind of pinpoint what makes
It's
me
a shirt,
Canadian.
Lester.
Yeah,
Yeah, that
of
shirt
course,
does
the
help.
love of right, the love of hockey and so forth, right? I was just really trying to pick up things that, like, am I Canadian because I'm not American, right? And one of the things that came up was, for me at least, was this idea of well, healthcare, right? Canadian healthcare being very, very core to who we are as Canadians, as a kind of a national identity. So maybe on to kind of dovetail off Costas' question is, obviously, why, what should we be looking for, but like maybe you can speak a little bit about like why, not just why this is important to Canadians, like what does it be, is it a core part of who we are as Canadians, that we should really be looking at this and not be looking at some of these other things, like understand trade barriers and so forth in terms of like we're feeling very, very much attacked right now. So there's obviously a motivation to look into that area around trade, right? But is that who really we are as people, right? It seems like as a nation, that is, we care for each other, being compassionate. That's kind of what, to me at least, being Canadian is more and more about. But sorry, go ahead.
Yeah. I think there's nothing more Canadian than our desire to care for each other. And we built our system on that assumption. And I've even heard some politicians say that we view healthcare as a human right in Canada. And that is a big difference from the US, more similar to many European countries. And so for me, that Canadian identity is sort of being unique, having gone out on our own, but still carrying some of the values that we brought both from Europe, but also a desire to improve our relationship with Indigenous people and help make up for some of the wrongs in the past and some of the ongoing harms that they're experiencing. Those seem to be really core to what it means to be Canadian, and a value of diversity as making us stronger, not weaker. That I always grew up sort of hearing like Canada's more like a salad and the US is more like a stew, where we value the different flavors and how they complement each other, not the way that they just blend into one general flavor. And I think that has been my experience in Canada, that the different backgrounds and experiences from people who have lived here forever and those who came from elsewhere have made a culture that is actually really multicultural and beneficial. But what we all care about is making sure that we are healthy and well and thriving. And that's what I want to see in the health system. I want to see us value the diversity of healthcare provider types, of rural versus urban, of people with different backgrounds, different languages, and creating those systems where everybody gets access to the care that they need and can be supported to be as healthy as possible and thrive in their home community. And so, what I would say if I had one message for everyone is that you're going to have candidates come and ask for your vote. And when they do that, ask them back, what are they going to do to make our health system and our health stronger in Canada? Because that is something that is core to all of us, that we care for each other and we want to be healthy and thrive in our communities.
Excellent. Thank you very much, Dr. Joss Reimer. And where can people find some of your work? Because I'm looking on your both the CMA website, so this Canadian Medical Association. That's cma.ca, and I believe you have a X account, but it seems like you've also have a Blue Sky account as well. Do you post more on X or Blue Sky or?
So the CMA right now is not posting on X just because of how it's being used as a tool to attack Canada, and
Mhm.
that's doesn't seem like a national health organization should be supporting attacks on Canada's sovereignty. But you can follow both the CMA and me. So I'm at Joss Reimer on basically every platform, whether it's Facebook, Instagram, Threads, Blue Sky, LinkedIn, same name on all of them. And the CMA is also on LinkedIn, Blue Sky, Threads, I believe, Instagram. So both, I think it's CMA underscore docs for Instagram, but it's Joss Reimer, JossReimer on everywhere. And we also have another for people who want to hear more about the health system and the challenges. We have channels called Healthcare for Real, which is aimed more at people who don't work in the health system to understand, why are ER wait times so long? Why don't doctors wear white coats anymore? And, what they talk about, do you lie to your doctor? Like there's a lot of really interesting pieces about what it's like to navigate through our health system, but they've got humor. And so basically love to see everybody there engaging with us. We have cma.ca/fighting for care is our election page, and people can see what they can do to get involved and talk to candidates, because we've got 20 days left before the federal election, and it really feels like we're at a precipice. We're at a really important point where we get to decide how Canada responds to what's going on, and so I want everybody to vote, and if you get a chance to also talk to your candidates about what you expect to see from them.
Terrific.
Terrific. Thank you very much again, Dr.
Oh,
Joss.
thank you.
Reimer for being on with us today. And of course, everyone, if you have any questions, comments, feel free to leave them down below. Of course, like and subscribe, and we'll put in the show notes all the links to the CMA, also to Dr. Josh Reimer's various accounts as well. So thank you very much for having this conversation with us, and everyone have a great day.
Thank you so much for the invite. Really, really enjoyed the discussion.
Thanks for your time today. Yeah.